I'd now like to ask another one of our medical advisors, all the way from New York in the USA, Dr. Cindy Neunert, who's going to be talking about the wider use of thrombopoietins. Cindy.
Thank you. So, happy to be back up here again. This is my from across the pond, my letter, my love letter from America, so to speak. So I'm going to talk about the TPORAs, keeping up with the platelets. I kind of also toyed with the idea of maybe not so new, but still novel. We've had a lot of discussions about new therapies coming out, but it's always important to see what we're doing with our current therapies. So this is not new now after some of these other speakers, but remembering how our TPOs are working. They're really working with our knowledge about what the changes are to the megakaryocytes, or sort of the parent cells to our platelets. And the understanding that our megakaryocytes in ITP may not be as healthy as we'd like them to be. And so the TPOs kind of come in and say, okay, it's time to rev up. We need more platelets out in circulation. I say it's kind of, if you want to win the soccer game, the best way is to try to have more players on your team. So this is what the TPOs are doing, is trying to get more platelets out in circulation to kind of have more platelets than we do antibodies and win the game. This is just showing the three different available agents, and all of these have kind of been woven throughout other presentations today. And it just compares them, and you can see there's some fundamental differences between them, but I think the ones that really matter most for patients are the way in which they're given. And we just had a discussion, and I've seen the same thing in my patients. When you sit and talk with patients, for some patients, the idea of an injection is really unfavorable. For others, a once weekly medication makes a lot more sense. And to agree with Nikki, it's usually my college kids that really just want that once a day and then they're done, and or the parent of a toddler that really doesn't have to mess with how do you not give milk to a toddler, or how do you work around a diet in a young child. With regards to side effects, they're all pretty similar, with the exception of the monitoring of LFTs that we do with L-thrombopag. And then at the moment, none are indicated in pregnancy, although there is some literature coming out surrounding this. So they're all monitored the same way and kind of dose titrated the same way based on a CBC. There's dosing nomograms for all of them. I will say I kind of sit down with my patient and figure out what their goals are of being on medication, and maybe adjust the drug insert nomogram a little bit to match what it is that we're trying to achieve with the patient, to really achieve the lowest dose of the medication that allows them to achieve those goals. They've all been shown, and you've seen some graphical representation of this, but really they've all been shown to increase the platelet count, decrease bleeding events, reduce the need for additional medications, and improve the quality of life of patients. Talked a little bit about the side effect concerns of thrombosis, and as was pointed out by Vicki, probably more related to other underlying risk factors, a kind of second hit type theory, where there's something else inherent to the patient that increase their risk for thrombosis. And then the bone marrow changes that were initially a concern, really we haven't seen in prospective studies looking at the bone marrow itself in patients taking these medications. So relatively good safety side effect profile. This last bullet point I will loop back to, and this is the notion that discontinuation will result in thrombocytopenia again. And we've already hinted at the fact that for some patients, this may not actually be the case. And some people can have a sustained response even in the absence of therapy. So here's just a graph. This is our graphical representation, just showing a platelet count of 50,000 and showing that the majority of patients receiving romiplostim were above that. Similar graph for L-thrombopag, showing that for the majority of patients, we're going to end up above that line. And this is just the graphical data from some of the avathrombopag showing average platelet counts. And so, again, all of these are kind of equal in efficacy if we were to line them up next to each other, and they all have very good visual representation of showing us that they work and are good therapies. So what about this notion of sustained remission off treatment? And this is a really nice summary of sort of the studies that have come out to support this. And there's variability in numbers and percentages, and that likely just represents the patients that were enrolled in the studies in the first place, the number of responders, how long they've been followed for. But you can really see here anywhere from probably 20 to as high as even 50% of patients have demonstrated a sustained remission off treatment. This may not be dependent on the dose or the duration of the treatment or which drug was received. So you can see here, this represents, we don't have as much data yet on avatrombopag. I suspect some will be coming out, but this looked mostly at just romiplostim and L-thrombopag, but really equal across the two therapies. So it doesn't seem to be limited to just one or the other. I did want to call attention to the IROM study. This study will be coming out shortly in terms of publication, but this was a large multi-center study. When we say single arm, patients only got drug. This wasn't a randomized trial, but they were looking to see if they could understand perhaps why certain patients are having this sustained free response. What's occurring to all of these immune cells that Dr. Semple introduced you to that's leading to this ongoing response despite not seeing therapy. And so what they did in this study is this was for patients who had failed first-line therapy. And what they did was they just gave them 22 weeks of the therapy and then stopped. So not how we typically think about using these drugs. So a little bit of a novel approach to say, we're almost going to do it like a course of steroids. We're going to give it, and then we're going to see what happens. This shows here, this just shows that of those patients that responded, so here's our responders, the platelet count was a bit higher when on therapy, and the drug needed to achieve that platelet count was a bit lower. So perhaps that is a marker. Those are the patients that maybe are going to be most likely to have this response. And then this and then this is shown down here, again, platelet count and dose in terms of showing that responders had lower dose to get a better platelet count. They're also doing a lot of biology studies. So they're really looking at exactly what we talked about earlier with the biology of ITP to see if they can identify the changes to the military that occur. So what did it look like before getting the drug, and then what happened afterwards? And can we identify what it is that's being reset by these medications to restore that normal signature and that normal control and regulation of the immune system? So more to follow on this, but I think it's a really important study to highlight, kind of asking this question. So when to start? I think this has been alluded to. Dr. Cooter alluded to it in one of his concluding statements. So I like that he kind of gave me a pitch for what we're going to talk about. But this is the when to start question. Earlier initiation of these medications may lead to improved outcomes. There's some indication that complete and partial responses are higher in patients that receive them earlier in the course of the disease. This is some data from a study looking back at 220 patients that were treated, just showing maybe a trend towards a higher response rate in those patients that were treated that were newly diagnosed. So again, earlier may be better. This is these are expert statements, and what was done here was they went out to a panel of experts and said, just rate your agreement with these statements. How much do you agree or not agree with these statements? And so the first was an early switch from corticosteroids to a TPORA spares corticosteroid abuse and improves long-term clinical outcomes. That was 100% agreement. Every single person asked agreed that that was a true statement. The next was if a TPORA is given early, there's greater chance of achieving a partial or complete response, almost 75%. And then earlier treatment with the TPORA is associated with an increase in clinically significant response, again, 75%. So I think there is, even without huge amounts of evidence, there is definitely agreement that earlier is likely better. We've had some discussions around using it in combination up front. This is two studies. One was dexamethasone and 28 days of L-thrombopag showing a nice early response and complete remission, complete response at 6 months of 50%. And then another study with 12 weeks of L-thrombopag and high-dose dexamethasone therapy, again showing about 50%. So some data that in combination, maybe there's an efficacy point even when used right away up front with corticosteroids. And I think it's really interesting. It's going to be great to see, you all have now had an opportunity to use these as first-line drugs, even in the absence of corticosteroids. And what can we learn from that? There's potential benefit from that change in practice that occurred with COVID in terms of what we can then learn in how we position and use these medicines. So I just like to, this is the love part of my talk, the love letter. I'm part of the Pediatric ITP Consortium of North America, and we are working on a study right now. We have an open study looking at pediatric patients with newly diagnosed ITP, providing them with either L-thrombopag or standard therapy, and this is the PINE study. What we're doing in this study is really looking to determine the proportion of patients that have a platelet count response if treated with L-thrombopag compared to those that continue on with standard therapies. And our primary outcome for this is really a yes/no, and it's do patients have a platelet count greater than 50,000 for the last week of the study for the majority of visits. Again, this is newly diagnosed. The way we define this is really we can either get kids right up front, but we also knew that might be hard to do. It's a really challenging time to sit down and talk to a family about randomization. So as long as a child's had ITP for under the 3-month window, even if they've failed a first-line therapy, they're still eligible to go on to this trial. We're looking at different age groups. Again, we want to see our young children any different than those adolescents and young adults that we just talked about in terms of response or how they do with therapy. And we are able to offer more children the drug versus the standard of care, which is also helpful when doing a clinical trial. And we're hoping to get about 150 patients on this. So this really is a large effort on our part. We've got about 30 different centers participating to try to reach our enrollment, and it's still ongoing. But I did want to highlight a lot of secondary outcomes because as we've talked about, looking at the platelet count alone tells us a small piece of the story, but really not the whole story. So we are gathering data on patient-related outcomes in this study: bleeding, fatigue, quality of life. We will be looking at cost. Unfortunately, that is a part of what we have to consider with these therapies. And then in terms of treatment, we're looking not just at platelet count, but need for additional therapies, need to move on to second-line therapies, remission rates at a year and at 6 months, and then adverse event reporting as well. And then we do have a biology component of this, sort of asking those same critical questions about what are we seeing on the very basic mechanistic level that might explain any of the signals that we see with clinical outcomes, and how do we relate the two to each other. So hopefully we'll reach our enrollment and recruitment goals. We had a little bit of a hiccup with COVID and in recruitment and enrollment, but we're trugging along, and we really hope that this will inform practice in terms of how and when to use these medications. So I think another question comes up, not so much even when to start, but when do we stop? Patients ask me this all the time. They say, so what do? We just stay on this? We stay on it forever? It's daily? What do I do? And I always say, too, it's important to have check-ins when you go on drugs like this. I say, we don't know. We don't have an endpoint. Some patients have been on these for years, but it's important to keep checking in. We're always going to keep checking in and make sure this remains the right medicine for you. So about every 3 months, I say it's kind of like taking your car, and every 3 months, we're going to sit down and really talk about this. We're going to go back to all of our same decision-making points that we talked about in the beginning and make sure that we're still on the right pathway. But this is just some guidelines in terms of when to stop. A lot of times we're stopping because of lack of efficacy. Maybe we're stopping because of unacceptable side effects, and we have to. But then there's also this notion of tapering based on response. And this came up in one of the talks earlier. And there is starting to be some guidelines surrounding maybe when we should start thinking about how to take a patient off of these meds, or when we should kind of have it in our mind that maybe this is a patient we could trial off. So just show these are the summary of different things that are out there right now. There's a paper from the US, a group from Italy, a European group, and then a Spanish group. Most say if you can have a platelet count of around 100 or 150, that's a good time to start thinking about if you could taper down. Duration was really variable, but it seems like 6 months. So if you've been on this for 6 months, you're still having a good response, that's still adequate time. I think it'll be interesting to see what we learn from the IROM study, which is only 22 weeks, as to how quickly we can start to see a response that might say we could come off. And then there was always some comments. There was really no consensus once we got to lower platelet counts about tapering off. So what about a threshold of 30,000 or 50,000? Is that still a patient to trial off? And then also looking at history of bleeding. So is this a patient where really I don't want to take that chance? Is there something about their past history that makes me a little bit more reluctant to taper them off? Do they have anything coming up? Is there any reason that their lifestyle may not be amenable to this? And then what other medications do they take? So we are moving towards some guidance on this about when we should try to think about taking patients off these medications. So I think it's important to not throw the baby out with the bathwater when it comes to the TPORAs. So I mentioned not having efficacy as a reason to think about stopping, but I'd like to highlight that means maybe stopping that particular TPORA, not the whole class or category. So we do have some data on switching back and forth between these agents. This is some nice data that just came out of Dr. Cooter's center, looking at patients who switched from ramiplostim or thrombopag to avathrombopag. You can see here the reasons for switching. And in these patients who switched, those that were not having a response to one actually had a good response to the other. So if there's something about the particular TPO that you're on, it's still, I think, worthy a discussion of whether or not switching to a different TPO might be of value before just throwing the whole class of drugs out the window and saying TPOs don't work. And this is some data on just L-thrombopag and romipilstim switching back and forth. And again, almost 75% of patients that went back and forth had a response if they weren't having a response before. So in conclusion, there's 3 TPORs that are available for the treatment. Switching between drugs is reasonable, and also selection of a drug to meet patient goals and lifestyle is also very important. Our data does suggest that patients can maintain a sustained response off treatment. Earlier use of TPORAs, I think, is being explored, and I think it's going to be really great to learn from your experience here with what you were able to do during COVID with early use. And then several guidelines are starting to shape how we can discontinue the TPORAs safely and which patients to identify for this. So thank you.
We've actually got a little bit of time for some questions here, if anyone's got any questions for Cindy. Colin, hold on one sec.
By its very nature, the training and experience of medics varies dramatically. Mm-hmm. There is constantly, because of the large amount of finance available, tremendous amount of expansion of studies of one form or another. Consequently, the spreading of best practice, it seems to me, is very limited. Do you not therefore think there would be a great scope for the introduction of AI?
That's a good one.
So I think that you are absolutely correct. I mean, we see this when patients come to us, the variability across practice. I think the other thing that occurs with a lot of patients with ITP is that they don't end up even with a hematologist, let alone an ITP specialist, right? They're being treated by oncologists or people less familiar with even the landscape of the medications themselves. So I do think that there are ways to consider how to build things in. I know on the US side anyway, this is something that the American Society of Hematology is looking at as best practice and how to integrate into medical systems. So electronic med systems, how can we flag? There's a lot of complications with that in terms of different systems not all being the same and the builds not all being the same, which makes it really tricky. But certainly the more we can get the message out, the more we can standardize. And I do also think this is where it's so important and so wonderful, the work that the patient support groups are doing to really also try to empower the patients when they go see a physician to have that knowledge, because again, recognizing not every physician might have that knowledge. And again, we can't really put this all on you all with every visit, but I would love to think about how to I would love to have a hard stop on a pediatric doc giving a kid 4 months of steroids. So if we can do that with some electronic way, I think that would be wonderful to put hard stops. But yeah, I don't know. That's great to think about.